So here's the big question we're looking at today. How do surgeons actually fix the human body's most complex plumbing system when things go catastrophically wrong? Because when these pipes leak, block, or just completely burst, well, it's an absolute emergency. How do medical professionals manage these critical reroutes, devastating leaks, and intense pressure failures inside our internal tubing?
Here is our roadmap for this explainer. We're going to explore 6 major mechanical failures and their surgical fixes. We'll cover rerouting the gut with stomas, managing leaks and shortages, pressure drops from diverticular disease, locating tricky lower GI bleeds, the ongoing battle of IBD, and finally, intestinal tuberculosis. Let's jump right in.
Section 1. Rerouting the gut with stomas.
Okay, the absolute crucial thing to grasp here is the mechanical difference between an ileostomy and a colostomy. An ileostomy is built from the mobile small intestine. Because it's way higher up in the tract, the output is really high volume and completely liquid. Plus, it's packed with corrosive digestive enzymes. Because of that, surgeons absolutely have to build it pouting out, kind of like a spout projecting above the skin. That way, the liquid falls straight into the collection bag without literally burning the patient's skin. A colostomy, on the flip side, uses the transverse or sigmoid colon. The output there is lower volume and semi-solid, so it can safely sit right flush with the skin.
But listen, these reroutes are definitely not without risks. Picture this. A surgeon is doing an emergency night surgery. Their most immediate, middle-of-the-night fear? Tissue necrosis. That's when the new stoma turns dark and literally dies because the opening made in the abdominal sheath was just a bit too tight. Day-to-day, though, skin excoriation is actually the most common complication overall, especially with those harsh, liquid ileostomies. And long-term, surgeons are always on the lookout for peristomal herniation. That's when another loop of bowel sneaks out alongside the stoma. It's the most common late complication for colostomies, and you can't just stitch it up. It requires a specialized mesh repair because simple stitches have a 100% recurrence rate.
Moving right along to Section 2, managing leaks and shortages.
We've got to start with one of the most distressing conditions a patient can face, a fecal fistula. This is an abnormal connection where bowel contents literally leak out through the main surgical wound, or worse, directly through the abdominal wall. The plumbing has essentially sprung a severe leak directly into the abdomen. It causes terrible skin damage, sepsis, and massive malnutrition. It's an absolute nightmare scenario.
Now, looking at the physics of these leaks, you'd probably think a short, direct leak is easier to heal, right? Actually, scratch that. It's the exact opposite. A long, zigzagging track is way more likely to heal on its own because the flow of the leak is physically slowed down. Healing is also favored if the patient is well-nourished, meaning their albumin is above 2.5. But spontaneous closure is practically impossible if any of the friend factors are hanging around. That mnemonic stands for foreign body, radiation, infection, epithelialization, neoplasm, or distal obstruction. If even one of those is present, that pipe is just not sealing up on its own.
So how do they fix it? Well, he can't just rush in and stitch a fistula up. It just doesn't work. Instead, surgeons rigorously follow the SNAP protocol. First, S for skin care and sepsis control. You have to stabilize the system. Next, N for nutritional management, aggressively feeding the patient intravenously with total parenteral nutrition. Then comes A, anatomical delineation. You have to map the exact leak with imaging so you know what you're dealing with. And only after all of that is perfectly managed do you reach P, a planned definitive surgery.
But what if your problem isn't a leak? What if it's a massive shortage of pipe? We call this short bowel syndrome. It's clinically defined as having less than 200 centimeters of small intestine left, which is a tiny fraction of what we normally have. The most common cause of this devastating loss? A superior mesenteric artery embolism. Basically, it's a massive vascular stroke that instantly kills off huge sections of the gut, leaving the patient dealing with severe, life-altering malabsorption.
So how on earth do you fix a pipe that's too short? This is where surgical ingenuity absolutely shines. One option is the Bianchi procedure. Here, surgeons take the remaining bowel, split it right down the middle longitudinally, and roll it into 2 separate tubes. Just like that, you've magically doubled the length. Another incredible option is the step procedure. Surgeons fire staplers in an alternating zigzag pattern all the way along the bowel. It is exactly like setting up those switchback barricades in a busy airport security line. It artificially slows down the flow of nutrients, giving that short piece of gut way more time to absorb food.
All right, Section 3, pressure drops and diverticular disease. Let's talk internal physics. So, diverticulosis.
I want you to think of the colon like a bicycle tire with weak sidewalls. When internal pressure builds up, usually from something as common as long-term constipation, the inner mucosal layer actually bubbles outward through those weak spots in the colon wall. It forms these tiny, vulnerable false pouches, mostly right along the mesenteric border of the sigmoid colon.
Having these pouches doesn't always hurt, but things can turn catastrophic fast. In fact, diverticular disease is the #1 most common cause of massive lower GI hemorrhage, especially when the pouches on the right side of the colon unexpectedly start bleeding out. But that's not all. These pouches can get severely inflamed. That's called diverticulitis. And this inflammation can escalate from a localized abscess, classified as Hinchey stage 1 and 2, all the way up to prevalent or fecal peritonitis, Hinchey stage 3 and 4. That is when the pouch outright bursts and dumps raw bowel contents straight into the abdominal cavity.
When a life-threatening blowout like that happens, surgeons deploy a rapid response tactic called the Hartmann's procedure. It's essentially brilliant damage control. They dive in, quickly cut out the perforated, contaminated segment of the colon, and then bring the healthy proximal end out as a temporary stoma to divert the flow. Then they just securely staple off the distal end and leave it safely tucked away inside the pelvis. About 12 weeks later, once the fiery inflammation is totally calmed down, they can go back in and safely hook the plumbing back up.
Section 4. Locating lower GI bleeds. Time for some high-stakes medical detective work.
Now, aside from those bleeding diverticula we were just talking about, the second most common culprit for massive lower GI bleeding, especially in the elderly, is angiodysplasia. These are basically fragile, dilated, and completely dysfunctional blood vessels hiding in the bowel wall, usually out in the cecum. And the scary part? They can suddenly rupture and just bleed profusely with absolutely zero warning. Tracking down the exact source of these bleeds is a strict step-by-step process. Doctors always start with a local exam to rule out the obvious, like hemorrhoids. Then they move to a colonoscopy. If that's clear, they actually pivot to an upper GI endoscopy. Why? Because sometimes an upper bleed is moving so incredibly fast through the tract that it completely mimics a lower bleed. But if all those scopes are totally normal, you're dealing with what's called an obscure GI bleed. That's when you bring out the heavy artillery, a capsule endoscopy or a technetium 99M nuclear scan. This nuclear scan is wildly sensitive. It can literally detect a bleed as tiny as 0.1 milliliters per second.
Moving to Section 5, the Battle of IBD. This is systemic warfare.
The absolute crucial takeaway here is understanding the distinct battlegrounds of Crohn's disease versus ulcerative colitis. Crohn's is a transmural attacker. That means it punches deeply through all the layers of the bowel wall, causing massive strictures and fistulas. It's totally random too. It can hit anywhere from the mouth to the anus, skipping over perfectly healthy areas and leaving behind this scarred cobblestone appearance. Ulcerative colitis, though, is more like a superficial, continuous burn. It only attacks the mucosal layer, and it always starts at the rectum and creeps steadily upward. It causes bloody diarrhea and carries this terrifying risk of ballooning the colon, which is known as toxic megacolon. This stark physical difference completely dictates the surgical philosophy for both diseases. Because Crohn's can strike literally anywhere, there is no definitive surgical cure. Surgeons are forced to be super conservative. They only cut out the absolute minimum to treat immediate dangerous complications, because if you take too much, you send the patient straight into short bowel syndrome. But for ulcerative colitis, we actually have a definitive cure. Surgeons perform a total proctocolectomy. They take out the entire colon and rectum. Then they fashion a brand new reservoir from the small intestine called a J-pouch. This effectively eliminates the disease from the patient's body forever. A real game changer.
Finally, Section 6, intestinal tuberculosis.
Intestinal TB is this master mimic that frequently attacks the terminal ileum. It's really fascinating to compare it against another major gut infection, typhoid. Both of them create severe intestinal ulcers, but they act completely differently mechanically. Tubercular ulcers are oriented transversely. They run right across the width of the pipe. So when they heal, they scar down and shrink, creating these incredibly tight strictures that cause severe mechanical blockages. Typhoid ulcers, on the other hand, run longitudinally along the length of the pipe. They don't usually scar. Instead, they carry this terrifying risk of bursting entirely right around the second or third week of infection, just pouring everything straight into the abdomen.
From navigating complex fistulas to bypassing blockages and reconstructing entire digestive tracts, the mechanical mastery of modern surgery is honestly breathtaking, but it leaves us with this final provocative thought.
As medical science, biologic therapies, and particularly small intestinal transplant technologies continue to rapidly advance, will we one day be able to just regenerate the gut's plumbing entirely? Will these complex, life-saving mechanical reroutes eventually become completely obsolete? It is an absolutely fascinating medical frontier. Thanks for exploring the brilliant engineering of the human gut with us on this explainer. Keep learning, and we'll catch you in the next one.